Yes, sir.
We're going to be doing left heart catheterization today. You're going to be our active participant. We have a lot of sophisticated technology that if you apply it to patients across the board, is it beneficial? I think to a certain degree, yes.
We lead the world in healthcare because we believe in a system of private medicine that encourages innovation and change.
Short BMW wire and the 014 iris.
Is it excessive? I don't think there's a physician out there that could honestly tell you that it's not excessive. It's absolutely excessive.
We have in the United States of America the greatest healthcare system in the history of the world.
Medicine has become a business. Physicians are reimbursed for doing things. We're not reimbursed for talking to patients.
The current medical care system is not designed to meet the health needs of the population. It's designed to protect the interest of insurance companies, pharmaceutical firms, to a certain extent organized medicine. It's designed to turn a profit. It's designed to meet the needs of the people in power.
We put forward a plan that makes sure that it is affordable to get health care that is as good as the health care that I have as a member of Congress.
They say they're interested in quality and lower cost and providing health care for everybody, and I want you to have the same health care I have as a congressman. I want to know what that is. Please tell me what that is and how good it is.
I want the CEO of this hospital to lay in a pile of shit for an hour, and I'm going to pinch her cheek and tell her that she's getting the best care, because that's exactly the experience we were having.
The United States doesn't really have better care than other Western democracies. It just has more care.
It's called the cyber knife.
Just one pill works all day and all night.
With the functional PET scans of the brain.
Some of the world's finest doctors. Chemotherapy, radiation.
Endovascular graft aneurysm repair.
So it makes my bones stronger.
Physicians can revise the patient's treatment plan.
ICD is a new device designed
to be safer and more effective.
There's an enormous amount of money to be made out there. And people who think that way have figured out how to get at it.
All right, I'm Dr. Northfleet, and Joel has been talking to you about the belly pain that you're having right now.
Yes, ma'am.
Is it the same kind of pain you've had before, Mr. Woodstall?
No.
Okay.
It started about a month ago.
The pain you're having now?
Yeah.
And who's your primary doctor?
I don't have one right now.
Okay. Have you been admitted to the hospital before, though? You've been here before?
I was admitted to the Centennial Hospital.
Okay.
I had chest pains, and that's when they found the hepatitis.
Oh, boy. Hepatitis B or C or
both?
Wow. You have a history of ulcers, anything like that?
No, ma'am.
And you haven't seen anybody else about this, huh?
No, ma'am.
Okay.
I went to the downtown clinic because when this happened, I wasn't able to work. I lost my job. I lost my apartment.
Okay.
And so I'm just trying to get help.
Yes, sir. We're going to help you, okay? He's complaining of vomiting blood. It's been going on a month, so it's not really considered an emergency anymore. It's considered a chronic problem. But we get a lot of patients like that the emergency department is the only place they know they can go to maybe address their problem. He didn't have the luxury of having a primary care provider, which is a luxury in this country, which is kind of sad. We're like the richest country, and a lot of our people don't have doctors, so they use the emergency department in order to see a physician.
You got a lot of congestion there in the back of your throat. You feel like it's kind of sitting there?
Well, that second to last tooth is infected, and the very back tooth looks broken off.
All right.
Over the last 12 years, the number of people visiting America's emergency rooms has soared. Yet here's what's surprising. The number of low-income people going to ERs has not increased. The increase has come almost entirely among middle-class people, and many of them have insurance.
Which insurance do you have?
Blue Cross.
Do you have your car with you?
Yeah.
So why do they go to the ER? Why aren't they seeing their own doctor?
Went home and...
Many people think that they know what's wrong with the healthcare system in this country. Millions of people are uninsured. And sure, that's part of the problem. But that's not the whole problem. The whole problem is bigger than that.
I'm up top here. Any problem up there? Any problem in the back? There's just not enough resources out there for not only your uninsured patients, but also your insured patients. The insured patients have a problem also because their doctors, when they call their office and says, I need to see, well, we can't see you for 3 weeks. Well, what am I going to do for 3 weeks?
Open your mouth.
Healthcare costs keep going up, up and up and up, but the access seems to be going down, 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 down. All right, do you need anything for pain right now? You do? Okay, we'll get you some. All right? And we got to run some tests and we'll be back.
Oh, okay. Thank you. I'm just glad, that there's a place to come to, I mean, dying's not no big deal to me, but, people have to go through a lot before they get there.
When I was a financial journalist at Barron's, I wrote many stories about health care. And what I learned was that much of what we think we know about health care isn't true. And much of what is true is counterintuitive. So eventually I decided to write a book about health care. And when I did, I knew I wanted to talk to a lot of doctors. So I began putting out phone calls. I didn't know most of the doctors I was calling. I was hoping that maybe 20% of them would return my call. To my utter surprise, 5 out of 6 of them called me back. And they talked. They talked for 30 minutes. They talked for longer than that. They said, please, we want someone to know. Please tell people. To a man and to a woman, what they were most passionate about was the declining quality of care in this country. Not about how much they were paid or how much they weren't paid. They were concerned about the quality of care, about what was happening to their profession, and how little power they had to do anything about it.
It is, I guess, politically correct, widely believed, that to say that American healthcare is the best in the world. It's not. There's a much more complicated story there. For some kinds of care, my colleague Brent James calls it rescue care. Yes, we're the best in the world. If you need very complex cardiac surgery or very advanced chemotherapy for your cancer or some audacious intervention with organ transplantation, you're pretty lucky to be in America. You'll get it faster, and you'll probably get it better than in at least most other countries. Rescue care, we're great. But most healthcare isn't that. Most healthcare is getting people with diabetes through their illness over years, or controlling the pain of someone with arthritis, or just answering a question of someone who's worried, or preventing them from getting into trouble in the first place. And on those scores, chronic disease care, community-based care, primary care, preventive care, no, we're nowhere near the best. And it's reflected in our outcomes. We're something like we're not the best healthcare system in the world in infant mortality rate. We're about like number 23. There's an index that is used in rating healthcare systems, which is the rate of mortality that could have been prevented by healthcare. There are at least a dozen countries with lower rates of preventable mortality than the United States, and not one of those countries spends 60% of what we do on healthcare.
Dr. Donald Berwick is a pediatrician and a revolutionary, really. He wants to overthrow a healthcare system he sees shot through with waste, inefficiency, self-interest, and disrespect for patients. Berwick believes that the people working in our healthcare system are by and large dedicated and caring people, but they're stuck in a stupid system. And he calls that a national tragedy.
If you look at the way we pay for care in the country and say, well, what is the underlying theme here? We pay for doing things. A piece of surgery, performing a test, doing a procedure, even a visit is a thing. So specialties or medical practices that do a lot of things, a lot of tests, a lot of surgeries, a lot of procedures, they'll tend to be the higher income earning specialties. Medical students leave medical school today with enormous debts. Primary care specialties are the lowest paying. If you have a choice between taking 15 years to pay off your debt or 7, you might decide on 7, and that means you can't be a primary care doctor.
blood pressure was obviously much better, but maybe we should have cut back on diazide rather than the altase. And why would you want him particularly, say, on altase, which is an ACE inhibitor?
It's shown to have more improvement for diabetic patients.
Yeah, yes. What particular function does it help preserve?
Renal function.
Right. It's called a cognitive specialty in most cases.
Yeah.
And if you look at reimbursement schedules, you'll see that cognitive procedures are not reimbursed as highly as someone who does cardiac caths or someone who does Botox or plastic surgery or whatever. When we pay primary care doctors to do good control diabetes, as well as we pay for excision of a skin lesion, or heck, I can do my shoulder injections that I do quite a few of. I do a lot of shoulder injections because I do a lot of musculoskeletal medicine, and I get paid far more for that than I do for talking to someone about their diabetes and hypertension. I wonder what your blood pressure is first thing in the morning.
What's interesting about the fee schedule is that it's all about what it costs the doctor to produce the service in terms of time and education. Never does anyone ask how much benefit is there for the patient. This might be a service that on average lengthens a patient's life by 5 months, as opposed to having your diabetes controlled for 30 years, which means that you live a lot longer and you never have an amputation. And yet we would pay much more for that technically very skilled procedure that gave you another couple of months, because we look at it entirely in terms of the work on the part of the doctor rather than the benefit to the patient.
Sure, he has a very soft, like 1 or maybe 2 out of 6 systolic near the apex. Take a listen. Let me see if we've ever evaluated that.
So we don't value primary care doctors, generalists, family doctors, highly at all. The compensation is relatively low, and that's why we have fewer and fewer of them.
Yeah, you get a little skip there. Albany Med's internal medicine residency this year, I believe none of them are going to primary care. They're all going to subspecialize in cardiology, gastroenterology, endocrinology, etc. I believe it's none are going into primary care.
I think I can hear it. It's very soft.
Yeah, it's very soft. It's a little mid-systolic thing.
Yeah.
It's probably nothing. Okay, deep breath in and out.
I'm a third-year medical student, so by October I need to have a decision in mind about what I want to do with the rest of my life. I do enjoy primary care because I enjoy the outpatient setting. I enjoy cardiology, which is a specialty field, so it's a hard decision to make. You've been having some nausea and vomiting?
Well, I haven't vomited.
Finances does play into the decision. People say that going into primary care can be a burden compensation-wise, and the worry about the future, like what does the future hold in terms of health care? Did it happen all of a sudden? Or? It's really hard to make a decision. I wish there was an easy way.
If the dollars-to-hours ratios were even vaguely similar between specialty and primary care, I'd choose it again every time. I like the variety. I like doing different things. I wouldn't like doing the same thing all day long. And I'm willing to take an income hit to be primary care, but it's affected the quality of the ability to deliver quality primary care in this country, because not enough people are going into it, and makes it harder to put together an integrated system. And everyone pretty much acknowledges that if someone doesn't have a primary care doctor and they go to multiple specialists, there's more duplication of services and higher total health care costs.
Do you have any pain when I press in your stomach?
There are very few relationships in which we're asked to take off our clothes and be examined by people with the idea that it's going to be safe to do that, and tell them about intimate parts of our history that we probably don't tell anyone else about. That makes it special. That's making oneself vulnerable in sometimes a fairly profound way. Or going under anesthesia for an operation. If someone says, I'm going to put you to sleep and we're going to cut you open and do certain things to you and it's all going to be fine and good for you, that's a pretty big leap of faith.
Larry Churchill is a bioethicist and one of the heroes of his profession, a discipline that struggles with the hardest moral questions regarding medicine. He doesn't just ask his students to wrestle with end-of-life care or stem cell research. He takes a clear-eyed look at the most difficult ethical questions regarding how you deliver care in a profit-driven system.
I think almost everybody recognizes that the obligation of a physician is to consider the well-being of their patients before their own self-interest. So I think physicians are always fighting in order to give the best health care they can provide. I mean, I have a very high regard for the profession itself, but they're under enormous strains.
I solemnly swear by that which I hold most sacred, that I will be loyal to the profession of medicine and just and generous to its members, that I will lead my life and practice my art of uprightness and honor, that into whatsoever house I shall enter, it shall be for the good of the sick and to the utmost of my power, holding myself far aloof from all, from corruption, from contention of others and hearts.
I think the current situation in healthcare in terms of the powerful market forces and the commercialization of the delivery of health services is fundamentally at odds with the trust and the kind of confidence that most people want to put in their physicians and what also most physicians feel about why they got into medicine to begin with.
Now if I keep this oath and break it not, may I enjoy honor in my life and heart for all time. Thank you.
We're now treating medicine as if it were an industrial product. Throughput. How many units of care can you deliver? The idea that you're going to see a patient on average for between 12 and 15 minutes, no matter what their condition, or how many kinds of problems they have, or how complicated their diagnosis, or how much reassurance they might need, is an idea that you can treat medicine like a production line product, and you can turn out patients in this same way like we produce widgets. That's a commercialization and an industrialization of the relationship. So this is a system which is fundamentally broken in terms of the kind of conflicts it raises in the minds of physicians and also in the minds of patients.
Right? Yes. Dr. Espinosa, nice to meet you. Hi, how are you? Karen, daughter?
Yes.
Wonderful, pleasure. Okay. Dr. Lynn was kind enough to send you in my direction, is that correct? Yeah. All right, very good. Do you have an understanding why you're here to see me? You can't just fix things in medicine. Medicine is a process. It's a duration of treatment that occurs over the course of somebody's lifetime. Yeah, there are things that we do that are very systematic and very matter-of-fact, so to speak, where you fix and boom, they're on their way, but it's just not a good way to develop a relationship. You need a rapport, you need trust, you need that patient, having the ability to say, yeah, Dr. Espinosa, that's my doctor. How have you been? Fine. The thing I miss most is being able to sit in a room and talk to a patient for an hour. But, we're so compressed with our time and the amount of patients that we have to see. 15 minutes is a long time these days. That's a long time. Basically, you get on an assembly line. Have we met before? I think so. Just get hooked up and chain keeps moving. Hello. It doesn't allow you to have an intimate relationship with somebody without someone else trying to always pry, that relationship apart.
Because you had told me to go to White House, I think, and I couldn't get there because they told me my insurance wouldn't cover it.
Okay. The insurance companies, are clearly in the room with us. Employers are in the room with us. You get into these issues of out-of-network, in-network. We're only going to pay 20% of your hospital visit versus 50% if you go to this hospital. These are all brokered deals and negotiated contracts and things like that in large insurance companies have with specific hospitals, with specific testing centers. So you're dealing with a lot of things that, this is not stuff that's taught in medical school. This is not stuff that, your partners are familiar with other than just being exposed to it. And we've kind of turned a blind eye or done the ostrich thing with, burying our head in the sand saying, we're just doctors. We want to just deal with what we do. But all of those other entities now live in our bedroom with us. You can't just pay attention to your wife and go to sleep at night. You're sleeping with 6 or 7 other people who are trying to break your marriage up. That's a big problem. It's a big problem, yeah.
When you go see the doctor, and the doctor listens to you and then sends you a bill, there's profit in that bill. That's the doctor's income. After he or she has paid the receptionist and the lights and heat and the rent and the equipment, he keeps the rest. That's profit. So as long as it's a human enterprise, yeah, at some level, someone's got to make some money, or they won't do it. So we're going to have profit, even if you call it a nonprofit system. Now, what are the incentives? Right now, the incentives in America are, if you want profit, do more. You make money by doing stuff, and there's no limit. So we do and do and do, and we get this oversupply, this excess activity, because that's how people, hospitals, doctors, make money.
Carl, we gave already a little cocktail from the bar. Alrighty, if you need anything more, just let us know. Right now, you're going to get a little bit of a local anesthetic down here in your leg. We'll start with the right heart. You know, if you're a hammer, everything looks like a nail. You know, I'm an interventional cardiologist, and that's what I do for a living, is I fix blockages. 6 French XP 3.5, please. Does the hospital like you doing lots of procedures? Sure, you know, these procedures, you know, are reimbursed fairly substantially. You know, even within your own group, there's a component of productivity. You know, you wish things would just be about taking care of patients and doing the right things, but, you know, are there external pressures? Absolutely. Absolutely.
You have to push the cath in, or does it find its way just naturally?
Yeah, all roads lead to Rome.
Terrific.
But at the end of the day, if you just remember the fundamental principle that you have to have done something for that patient in order to make them feel better, live longer, you know, engage in a lifestyle that they weren't able to engage in before. And if you stick to those principles, it allows you not to kind of drift from what you know is right and fall into this arena where, you know, you're just slamming a stent in every blockage that you see. Because if you did that, then, you know, clearly it becomes, you know, I would hate to use the term immoral, but, you know, it becomes an issue where you're doing things just to do them, not because it's the right thing to do.
All right, hold your breath, Miss Deemer. Don't breathe, don't move.
So at the end of the day, you know, you fall prey to the fact that we have a lot of technology. Is most of it necessary all the time? Probably not. Probably not, but we use it because it's there.
We all know the anecdotal successes. You know, Uncle Harry had an arthroscopy, and all of a sudden he's, you know, playing in the NBA again. Or Uncle Joe had a heart bypass, and he's doing great. Now, we don't know that Uncle Joe or Uncle Harry might not have done just as well without that procedure, but you see something happen, you see someone get better. It's natural to think, this is it. And those kind of procedures are just very, very appealing. We're a technologically intrigued society. That being said, more technologically intrigued societies, Japan and Scandinavia, don't spend nearly as much on technology and medicine as we do.
There's an awful lot of technology involved, even in ordinary outpatient kind of encounters now. We have been so good at finding new and innovative ways to treat illness, and we love this. The idea that technologies can be turned into cures is really a fundamental thing in our society. So we don't take a public health view about how can we improve the health of the country? Clean air, clean water. We do some of that, but we don't think about, for example, the care of indigent women when they're pregnant. We don't think about nutrition and education, which are very powerful forces determining how healthy we are as a people. No, we think about technological interventions.
Okay, 3D roll, please. Thank you.
You're pretty good there, huh? The more you kind of step on the pedal and fast forward with medical technology, something gets left behind. I think where we lack is that kind of one-on-one patient interaction, developing patient trust and having rapport and relationships with patients. I think that's where we've lost a little bit.
Just take some nice deep breaths, okay? All right. So this was the blockage before. You see this kind of long, skinny area here?
You know, with the beauty of the technology we're able to offer, you know, medical conditions that would have planted a patient in the hospital for weeks, sometimes even months at a time, you know, they can come in, have a heart catheterization, and be home the next day. That disillusions patients, unfortunately, about the magnitude of their medical condition. You know, you have people who come in and say, oh, just, you know what, just give me one of those stents, you know, I'll be fine, I just want to go home, not really understanding the process of coronary disease or the implications of their heart disease, you know. So we struggle with that because, you know, everybody wants a quick fix.
Sometimes patients get sucked in, we all do, to let's have another procedure. You know, my knee is killing me, let's have an arthroscopy. I have a little angina, instead of trying some simple medicine, let's try surgery. I mean, we're all tempted to do this. But yeah, there is, and there's a lot of healthcare dollars spent on marginally effective things, and sometimes there's side effects from those marginally effective things.
I think the main driver, the difference between our costs and other countries' costs that have healthcare systems as good or better than ours, is supply-driven care. It's this work that Elliot Fisher and Jack Wenberg have explored at Dartmouth. It's that we overbuild and therefore we use, and there's no limits, there's no cap, there's no control, and so we just spin the wheel.
What's truly staggering is how much waste there is in our healthcare system. Up to 1 out of every 3 of the more than $2 trillion that we spend is wasted on ineffective, often unproven procedures, overpriced drugs and devices that are no better than the drugs and devices that they're replacing, unnecessary hospitalizations, unnecessary tests. Now, this may seem like an overstatement. I mean, how can it be that 1/3 of the money is wasted? We actually have close to 3 decades of research done by doctors at Dartmouth University proving how much waste there is in the system. What the Dartmouth researchers ended up doing was looking at health care all across the country. And what they discovered is that in some high treatment states, like New Jersey, Medicare was spending 20% more per patient than the average. And in other low treatment states, like Iowa, Medicare was spending 25% less than average. They tended to focus in on what happened to patients during their final 2 years of life. So in that way, you were comparing apples to apples, pretty sick patients. Then they began looking at sick patients who had the same disease, etc., finding these enormous differences in what Medicare spent. Some people said, well, maybe patients in New Jersey are simply more demanding than the stoic citizens of Iowa. But in fact, very few people demand a chance to spend more days in the hospital during their final 2 years of life. Very few people cry out for a chance to die in an ICU, or to have that 4th procedure, or to be poked and prodded by 11 or 12 specialists during your final 6 months of life. In the states where Medicare spends more, these are the things that happen to people. They're getting more aggressive, intensive, and expensive care. And here's the stunner. The outcomes are no better. Often they are worse on average in states like New Jersey or New York or California than they are in low treatment states like Iowa or North Dakota.
I'd like to suggest that if we looked at the population of people with a problem, back pain, and said how many MRIs do we think we need to do as a nation, we could probably cut the number in half and not have hurt anybody. Yet we keep opening more and more MRI machines and do more and more pictures. They're beautiful. They're incredible. Incredible technology. But then that causes somebody to have to make a decision about a back surgery that maybe they didn't need.
You have a situation where the doctor provides a service, is paid for providing the service, and controls to a significant extent the demand for that service. This is not I saying, I'm going to get a high-definition television. This is a doctor saying, you ought to have a high-definition television. More correctly, you ought to have an MRI or a CAT scan. It's called for in this situation. Who in the world? I don't have the ability to say, is this MRI necessary?
Oftentimes people say, well, If people are getting these ineffective, unproven procedures, why don't the insurance companies just say, no, we won't pay for it? I mean, we all know that insurance companies like to deny treatment. That's a big problem. The fact of the matter is that insurance companies tried saying no in the 90s, in that era of managed care, when a great many HMOs would say, no, we're not going to pay for that. The problem is that HMOs made their decisions on what they were going to pay for based too often simply on cost. If something was too pricey, they would say no. But they weren't looking at the quality of the procedure. They weren't asking, well, would it really benefit the patient? They were simply saying, well, where does it fit on our schedule of costs? So sometimes they denied ineffective, unnecessary, expensive care, and sometimes they denied very good, effective, expensive care. There was a backlash, needless to say, in the media, on the part of patients, on the part of doctors. So by the late 90s, HMOs began to say, okay, we won't try to manage care. By and large, we will pay for whatever Medicare